on total hip arthroplasty in pelvic discontinuity. So I'd start off with an example. This was a 38-year-old male who came to us post-op after an acetabular fixation was infected. We went in posteriorly, removed the implants, put in a spacer. 6 weeks later, we went in with a cemented cup with a minimal bone graft. However, 7 months later, the obvious happened. There was lysis and there was loosening of the cup. So we had to again go in, this time debride it properly, and again take out the implant, and he had to have a staged procedure with the then available octopus cage and allograft, and that is him at 9 years follow-up. So pelvic discontinuity can be subtle issues that can be sort of underestimated intraoperatively. Now pelvic discontinuity or pelvic dissociation has to be carefully noted intraoperatively, and what we have to understand is that there is a separation of the ilium from the ischiopubic segment, and it can happen in acute situations in the elderly, well, iatrogenic fractures at THR, and more often than not, well, unrecognized iatrovision THR. In addition to an X-ray, what would be a very, very useful tool is a CT scan with a 3D reconstruction, which would give you adequate information regarding planning, residual bone stock, and also the reconstruction that would be required in addition to looking at the status of the ischium. Now, if you have the principles of management, you restore continuity, basically establish the connect. You need bone graft because you need some potential for bone formation. You need optimal contact with the remaining host bone, and obviously you need mechanical stability at reconstruction. Now, healing potential has to be evaluated depending on the duration, and also it has to be evaluated properly so that you achieve bone union when you go ahead and do the total hip replacement. Now, look at this individual who came to us 2 years post to arrive with pain and AVN. Obviously, there is an element of pelvic discontinuity. And all that had to be done was this: once the implant was removed, we had to assess at reaming, and obviously a subtle form of non-union could be established. We use the head, use enough bone graft to bridge it, use the principle of a slightly bigger cup, distracted, and this is him at 1 year follow-up with showing good union and good bridging across the fracture site simply by using a good mechanical stable fixation. Now, this is a gentleman who came 1 year post-op with a femur fracture and also with a pelvic discontinuity. Obviously, the CT scan revealed the inevitable, and he had to undergo a staged reconstruction again. We redid the acetabulum at stage 1, basically when we removed all the implants, put in a spacer, but then he had to be reevaluated at follow-up, where he required again some fixation which had to be redone so that you have additional stability with an augment fixation, and this is him at 9 months follow-up showing evidence of union and also restoration of the hip center and also getting back to the center of rotation. This is a 52-year-old lady, 2 months post-op, fracture neck of femur, obviously no infection, but the CT again showing the fact that there is an element of pelvic discontinuity, and the best solution in this situation would be to use a good porous coated cup with augments to get that situation or get that bridging done and thereby establish what we call the continuity, and that is her at almost 2 years follow-up showing a good bone reformation, good establishment of healing potential as well. So what are the treatment potentials or treatment options available? I think Paprosky and Neil Sheth have described this very, very well with their paper on distraction technique, and that's a very, very good solution for situations, especially where you have neglected or other pelvic fractures that are coming, especially with implants in situ. Again, we do not hesitate to remove it even with the slightest suspicion of infection, because you have the ability to redo the spacer, evaluate your pelvic discontinuity, plan for your future fixation, and come back. This was him with the CT scan just before fixation, and this was again done with an augment and bridging across with the fixation so that we can do the actual fixation and getting an ideal stable construct. This was a 43-year-old lady. This was one situation where we used a jumbo cup, because this was one situation where this jumbo cups we thought in the initial phases would do the trick, but this is something that is good in select situations. However, there is always a danger of abduction failure. Fortunately for us, this lady who's right now, I got this X-ray at 9 months post-op, even later she's doing quite well, but I would hesitate to do it now, knowing that we can also achieve what is called an inferior or a 2-sector fixation. Lady 17 years post-op, again CT scan, getting a CT angio as well to be sure. Cup done. We have a cup cage construct which if you look at the traditional or the actual cup cage concept that's available in India from the Zimmer TMAS, it is not a good size that is available for our Indian population. We can do a modification where you use a TMAS cup and do something like an evolutus cage and then cement in a liner, and this is what she had at the end of it with a cup cage construct. This is again another lady who underwent fixation as well as a redapt cup with the fixation with the inferior sector and a cemented cup cage construct. Again, most are post-acetabular fixations, spacer done, and this is one good addition to the armamentarium that we have, getting that pubic screw. If you can screen to get a good pubic screw inferiorly, I think that's the best solution where you can get two sector fixation with an inferior and a superior sector fixation and get on to a good stability with the construct. One thing to bear in mind, most of our traditional multi-hole cups will affect the version if you try to put in that inferior sector screw. This is a very good addition where the redapt cup offers the solution for that screw fixation without affecting the version, and you have the option of cementing in the cup or doing an uncemented liner, and that's a very, very good addition, especially for pelvic discontinuity. So bear in mind that complications are 25 to 80% if it's not properly done, infection, dislocation, and revision could be as high as 30 to 40% if this is not properly addressed. So you have anteroprotrusive cages that are also being described. However, people are moving towards a cup cage construct, and augments is definitely the go-to for a situation like this, where we have the true cup cage construct provided by Zimmer, but however the sizes don't match in our situation, so we can use a modular or a customized fitting for our situation. Restore continuity, stable fixation in at least two sectors with the pubic screw, optimized bone stock, bone graft, mechanical stability, cementless is preferred, and remember that chances of failure and revision are high. Thank you for your attention.